I'm just going to present to you three things: the LH surge, the unruptured luteinized follicle, and probably endocrinology of the stimulated cycle as well. So this is a very important paper which talks about the luteinizing hormone surge and other characteristics of the menstrual cycle. And all the menstrual cycle characteristics can be easily altered by the emotional and physical setup of the lady. So if there is stress, there's physical or emotional stress, or insomnia for that matter, all that will have different menstrual cycle, duration, amount of bleeding, etc. will keep changing. Especially these changes will be exaggerated in women of advanced ovarian women age, low ovarian reserve, and the way the LH will surge will keep varying in all this population. And this is very important for us because loads of us keep doing natural cycle, frozen embryo transfer cycles. And if you leave it to the nature, there's a possibility that the LH surge will be different and that may not give us a good pregnancy rate. So we must understand what are the different kinds of LH surges which exist in our population. So LH surge, not necessarily every LH surge is a 14 hours peak, then a 14 hours of plateau and a 20 hours of downfall. And the whole surge is lasting for about 48 hours or more. So it is assuring a meiosis as well as a good luteinization of the follicles. So LH surge can be a single peak as it is shown, or it could be a delayed peak. You could have a double spike LH surge, there could be a prolonged LH surge, there could be a typical plateau LH surge. So there are different variations. And all these variations are because of hypothalamo-pituitary axis functional differences, which could be just stress-oriented. It could be obesity will have a different LH surge, or thin women will have a different LH surge. And that kind of LH surges will vary from cycle to cycle. So we cannot expect every lady to have a perfect LH surge every time so that we can time things up. If there is a high, obviously there will be a late follicular estradiol levels will go up, and this late follicular high estradiol levels, that will give a positive feedback, and wherein the LH will go up. And this increases the GnRH receptors onto gonadotroph. So the estrogen, as it grows up, it builds up the amount of GnRH receptors into the hypothalamus. Also, the estradiol reduces the GnRH metabolism. So whatever GnRH is there, it doesn't get degraded. It remains there in the hypothalamus for a prolonged time. So more GnRH will be available for the gonadotrophs. And because the receptors are very high, it reduces the threshold of GnRH to the pituitary. So all that makes a very conducive atmosphere for the GnRH pulse to begin and the LH to go up. What we have always understood, a typical sentence from Spirov, saying that if the E2 is beyond 200 picogram for 50 hours, the LH surge will begin. But that's very half understanding, because those days letrozole was not there. The moment letrozole has come up, we've been able to successfully keep the E2 levels through the follicular phase, maybe less than 200 picograms. But in spite of that, the LH surge is there. Not only that, if you compare clomiphene citrate, letrozole or HMGs, the best LH surge you get with letrozole when your E2 levels are kept low. So Hurst et al., when they did study, they said when you give continuous letrozole in ovarian stimulation, keeps the E2 low, but the physiologic surge is seen and a good surge is seen. So it is basically not to do with the estrogen, but it is to do with progesterone. So pre-ovulatory, a small rise in progesterone or progesterone peak, only by about 0.5 nanogram, that is enough to give a surge. We commonly see women coming to us with anovulatory delays of menses. She has a dominant follicle. We give maybe progesterone or primoluten or something to get menses, get a withdrawal bleed, and she comes out next and, well, I never bled, but now my UPT is positive. So your progesterone acted like a spike that gave rise to an LH surge, and she achieved pregnancy. So it is not the estrogen, it is the progesterone. But where is this progesterone? Where does this act? This progesterone acts at the hypothalamic level. So it's called neuroprogesterone. So at the hypothalamic level, when the estrogen levels are peak, the estrogen goes up and stimulates the ER alpha receptors in the hypothalamus. And this ER alpha receptor synthesizes more amount of progesterone and puts into the hypothalamus. And this rise in the progesterone in the hypothalamus gives rise to a quick GnRH surge, and that itself is called an LH surge later. Luteinization is by default differentiation of a granulosa cell. Every granulosa cell will ultimately get luteinized. A small progesterone released acts on the hypothalamus, actually facilitating the surge, And this is what I told you. And follicle may rupture. So the follicle may rupture without an LH surge. There is a possibility that LH surge doesn't take place, but the follicle will rupture. But there is a rupture, difference in a rupture and ovulation. Ovulation means rupture plus a meiotically competent oocyte is released. And not every rupture without LH surge will have a meiotically competent oocyte release. And this typically you will find in old age women. You've seen a follicle till 14 millimeter and you say, well, you come after 2 days, then we'll give you a trigger and do an IUI. And she comes after 2 days and the follicle is already ruptured. This is very typically seen. But the rupture physically is seen, but there is no release of an egg there. Then if this is so, that a follicle can rupture without LH, what's the role of LH? What's the role of LH surge there? So LH basically combines these two events. So ovulation is a combination of mechanical rupture of the follicle and meiotic division being completing. So maturation being completed of the oocyte. So a good metaphase 2 oocyte is then released. And these two events have to collide with each other. And that's what LH does. So oocyte has an optimal fertilization window from 37 to 41 hours after the HCG, and rupture and meiosis must coordinate. And this coordination of meiosis resumption and rupture is managed by the high LH level or the trigger you give. So it also causes loosening of cumulus cells and the rupture event will take place. This is another mechanism which has been described in the literature, that the follicle is generally in an avascular phase, so it is hypoxic. And because it is hypoxic, there is enough amount of endothelin-1, which does not allow progesterone to act. As the follicle grows, as I told you in the morning session, it moves toward the medulla. It goes near the capillaries. So the hypoxia is removed, and the endothelin-1 stops. And that's where the progesterone comes in, and that gives rise to a GnRH trigger. So a trigger, or you're not a trigger, the LH surge is more to do with progesterone release rather than the estrogen. I'm no way saying that a high estrogen will not surge. It will definitely, that's the way we understand. Definitely there will be a surge. But the core event is a small amount of progesterone there. That means it is nicely mature. You all must have heard about this premature progesterone rise, the premature luteinization. What we mean by premature luteinization? Any LH going beyond 10 during the course of stimulation, we will call it luteinization. But the thing is it accompanied by rise in progesterone or no? If it is accompanied by a rise in progesterone beyond 1.5, then say, well, it can make some difference to the endometrium. But if there is no rise in progesterone, it will not make any difference. Rather, it will be very good. You'll get a better outcome in this particular cycle. Having a high progesterone level at the end of stimulation is a marker that you are going to get more mature oocytes. So many times in oocyte donors, if I want to get a good yield, I have decided I want to give a trigger. And my associate says, no, doctor, sir, we'll trigger it tomorrow, we'll trigger it today, and I want to trigger it tomorrow. I said, get a progesterone level done. Only the progesterone, but the E2 is going to be high anyway. If the progesterone comes 0.8, I say, well, go for another 2 days, and we'll trigger later. If the progesterone comes 1.52, I said, trigger, this is the right time to trigger, and we'll get good amount of mature oocytes. So don't look at that late follicular progesterone rise as an adverse marker. Actually, it's a physiological marker that your oocyte has reached to the stage of maturity. And obviously, this is the mechanical part of the rupture, where there's rapid LH and FSH release, fluid accumulation, cumulus disperses, meiosis resume, and the whole thing, ovulation takes place. So there is a progesterone paradox, isn't it? You have this mini pill, that's your progesterone-only pill, which inhibits ovulation. So if progesterone is given continuously above the gonadotrophin surge triggering threshold, like in oral contraceptive pill or in mini pill, the pregnancy desensitizes its own receptor. Progesterone will desensitize its own receptor, and LH accumulation and surge is not possible. Okay. Only in a follicular phase, in an estrogen high environment, a small rise in progesterone, because gonadotrophin, your estrogen has allowed a lot of gonadotrophins to accumulate in the pituitary, and the GnRH sensitivity has increased, and that will give rise to surge. So this is a progesterone paradox which we must understand. What about luteinized unruptured follicle? This is such a common thing, isn't it? And there are various terminologies used for this LUF. And how will it present to us? Probably you are given a trigger and you call after 4 days and the follicle is not ruptured. How many of you practice IUI only after seeing a rupture? Don't practice that. There's no evidence to practice that. You have to just practice doing an IUI between 36 to 42 hours and you're through it. So this is one common presentation. They're given a trigger and the follicle is not ruptured. What could be the pathophysiology behind that? There's a possibility during the course of your stimulation, your E2s went up, the lady triggered by herself. You're not detected because you never tested for it. So her LH did go up, maybe to 40, 50, 60, whatever, and that luteinized the follicle. And now you're given HCG. The HCG cannot act on already luteinized follicle. Okay, so it will just persist. And that earlier LH surge was not good enough for follicle to rupture, so it will just persist as a luteinized unruptured follicle. Second could be, the other endocrine problems could be, how will it affect in the luteal phase? So a luteinized unruptured follicle in the luteal phase can perform two ways. One is a typical way and one is an atypical way. And this is called luteal phase dominant follicle. A luteal phase dominant follicle, typically in the luteal phase, before the start of the next follicle phase, it will disappear. That's called typical. Atypical means it will persist even in the follicular phase. And what you have understood till now, if a follicle persists in the luteal follicular phase, which we call a residual follicle, we say, well, we don't want to start stimulation. Am I right? We say we don't want to start stimulation. If it is an IVF cycle, do start stimulation then. Because what is this follicle doing? This follicle is giving more amount of estrogen. And it's like acting as if you are given pre-menstrual progynova. The follicle is functional, it is atypical, it is ever growing, maybe 3 centimeter, but it is giving rise to estrogen. That estrogen is not allowing any FSH to go up, and this big follicle is also secreting inhibin. So estrogen high, inhibin high, the FSH, which is supposed to go high before the onset of menses, has not gone in at all. So even if you see that follicle of 2-3 centimeter, look at the other antral follicle count, and believe me, that's the right time to start your stimulation, rather than cancelling it. I see a lot of people giving OC pills. So nature has given you a scenario, kick off your stimulation, and you say, no, I'm not interested. I will give OC pills, I'll suppress you badly, and then I'll start stimulation, and then I'll have a face problems. Don't do that. OC pill is pakka no in all your IVF practice. So this is a beautiful paper again by Bashir et al. Of follicle growth and endocrine dynamics in women with spontaneous unruptured luteinized follicles. He says that it is quite repetitively. We do see LUF very repetitively in certain kinds of patients. It could be a failure of rupture and thicker follicular wall compared to ovulatory cycle. And this you can see even on sonography. An ovulated follicle and a non-ovulated. Non-ovulated will have a thicker follicle wall. It may have some echogenicities into the follicle itself. Obviously, you may see some hemorrhage as well there. And one of the reasons that thicker follicle wall, just not an ultrasound picture, but it could be a thicker follicle wall which is having repeated LUF, for example, endometriosis, pelvic inflammatory disease or pelvic adhesions, post-operatively. If there are, because of adhesions, the ovarian wall has become thick, obviously it won't rupture at every ovulation, and you having repeated LUF will be very common. Echogenic foci in the follicle, these are the ultrasound parameters. Commonly, LUF is because of low systemic LH. Your LH surge has not been good. That's why I showed you the different kinds of LH surges. If you have a single spike LH surge or double spike LH surge or a prolonged LH surge, that's not an adequate LH surge to cause a rupture, and that's why LUF is there. So LUF means the LH has been low. So if you find an LUF after giving HCG trigger, that means your trigger has gone late. You should have caught the follicle younger before she innately had to put her LH up. If that would have been done, your HCG would take the LH-like activity to a very high level, and this would not have occurred. So if you get this kind of a client, you give an HCG, it has not ruptured, next time give your trigger a little early, and that would make a difference. Intrafollicular dysregulation of PG may be a reason again. Low LH in early development is there, and if that is there, there will be upregulation of LH receptor. LH receptor is hungrily sitting there, and that because of that, as soon as the LH starts going up, there will be just early luteinization and failure to ovulate will be there. And high progesterone in LUF is because there is early luteinization and progesterone secretion comes up. And I found this is very important paper. This paper told us about, this is a common practice for all of us, isn't it? We do either clomiphene HMG cycles for IUIs or letrozole HMG cycles for IUI. And LUF is more commonly seen with clomiphene cycles and less with letrozole HMG cycles. Okay, so this is we need to keep in mind that letrozole HMG will have less LUF. So you're having repeated LUF, think of giving letrozole HMG and not clomiphene HMG. How many of you are using clomiphene in your practice more commonly? Yeah, it is a wonderful drug. Okay, because if you go through the literature published on the onco-fertility, they are given letrozole in combination with HMG stimulations, and it's all random start. They give letrozole because they want to keep the estrogen levels low. But believe me, what does the follicle strive on, the granulosa cell strive on? Estrogen. If you keep the intrafollicular estrogen levels low, not just the system, you'll keep intrafollicular as well, the oocyte may not be greatly competent. So the studies are on either side. Okay, you really have to be very selective in your population. It's a shared decision making in which oncofertility you will give letrozole in combination with stimulation, in which you may not. For example, I'm facing a lymphoproliferative disorder for whom I'm doing an oncofertility workup. Well, I may not give letrozole. I'm having a breast cancer patient with a high receptor, young. I'll have one discussion with my oncosurgeon, oncotherapist, and then I will plan it up. And I will plan it up in such a fashion that I will give letrozole huge amount as soon as my trigger is done. I give trigger OPU. On the same day, I will start maybe 10 milligrams of letrozole every day for 5-6 days. Get the E2 slashed down. Just 14-15 days of E2s, maybe reaching about 3,000 wouldn't harm it that badly. But otherwise, the E2 will deteriorate oocyte morphology and your yield will suffer. Because E2 is very much needed to maintain a good atmosphere of the follicle. It all strives in estrogenic milieu. So I'm not a very hardcore favorite of giving letrozole and HMGs in my oncofertility group. I prefer giving new stimulation, give letrozole at the end of pickup, and then the E2 levels is looked after later. Anyway, within 2-3 days, they are going to start their chemotherapy cycles, so it wouldn't make much of a difference. Let's understand a bit about stimulated cycle endocrinology. And I'm quoting this author, Ioannis Mezanis. He's from Greece, and he's been consistently publishing, and he's telling progesterone-primed ovarian stimulation is completely redundant, he says. And why are you using antagonists? Antagonists are not needed. And that is, we'll try and see what arguments he puts over there. So this is what we understand. The follicle recruitment starts 3 or 4 days prior to the onset of menses because the FSH starts rising there. So when the client comes on day 2, this is a typical diagram. I just borrowed it from Sharayu, saying that you have some follicles who are larger. The blue ones have already started responding to the FSH, which started 3 days back. The yellow ones, threshold of FSH is not yet reached. And when you start stimulating, the blue one will also grow, the yellow one will also grow, and at the end of the stimulation, you will have an asynchronous growth of follicles. But you want it to be asynchronous growth, and that's why you're doing IVF. All the idea is to have asynchronous growth, but you're not able to avoid this when you do an antagonist cycle. What happens to the LH levels? In the first phase, or the first 5 to 6 days of stimulation, when the estrogen is going up and the follicle is still between 8 to 12 millimeter, the oocyte factor is secreted. The follicle secretes a local factor. It is called gonadotrophin surge attenuating factor, GNSAF, which does not allow the pituitary to sense the rising level of estrogen, and the LH surge does not take place. So all the follicles are secreting GNSAF, which is not allowed. So premature luteinization is not allowed. As the follicle grows beyond 12 millimeter, the GNSF expression comes down. Now, estrogen alone is there, and that estrogen will increase the risk of premature luteinization in the absence of your GNSAF. That's what Mezanis says. But he says when the premature luteinization takes place in a high estrogenic environment, the LH surge is not very high. The LH is always attenuated. It doesn't go to 90 and just everything ruptures. No, it doesn't happen that way. So he says the LH doesn't go up that high. And if you feel it has gone high, just give a trigger and take it out. Go ahead and complete your pickup. There is no need to use an antagonist or progesterone whatsoever. But not many of us are still convinced, and we don't practice that. Why? You should go through the paper. I'll send you the paper and the book chapter on this. Because we see extremes of our patients. We have a real world scenario in our patient, and the studies are never done on real world scenarios. The studies are done excluding polycystic ovaries, excluding endometriosis, excluding women beyond 38 years of age. But they are our 50% of our day-to-day clients. So we cannot apply this study as it is to our population. Look at a polycystic ovary. You have a polycystic ovary lady, what Dr. Goody was showing, and you give about 300 IU of HMG to her, or 225 HMG, and you suddenly have on day 6 about 20 follicles who are 9 to 10 millimeter. Isn't it common? Very commonly seen in polycystic ovary. So now estrogen is going up. Estrogen is not 500 and 400, it's 1200 on that day. And now that high estrogen, so now the GnRH sitting there has to see, भैया मैं GNSF के पास देखूं या estrogen के पास देखूं? And these patients the LH will go up and will not be hampered, not be completely controlled by the amount of GNSF, though the amount of GNSF is also high because large number of follicles are there. The studies or the literature does not mention any cutoffs here. And why even a small rise of 20 of LH, let's say LH goes to 20 in this particular case, it will still affect badly because it is polycystic ovary. In polycystic ovary, the LH receptors are seen as early as 6 millimeter. And if that 20, I told you in the morning lecture, that LH premature luteinization, a low LH high is required to affect the smaller follicles. A high LH is required to affect the larger follicles. So this 20 will affect those smaller follicles. All are small only, and their luteinization will take place, and that will completely stop the follicular growth. So in a PCO stimulation, what do we say? Give antagonist a day earlier. Start it on day 5. After 4 days of stimulation, day 5 you start an antagonist. Probably you will do better rather than delaying it up. So this Messinist theory cannot be applied to a real world scenario. Look at the other client. Other is a low ovarian reserve or advanced age patient. She has a follicle, only 2 or 3 follicles. Is there an amount of GNSF there? No, hardly any GNSF will be there. So the pituitary axis is not badly suppressed. Once the follicle goes to 14 millimeter, we start antagonist. Am I right? In FlexiStart? In a low ovarian reserve patient, an advanced age patient, you need to start antagonist when the follicle is 12 millimeter. But by 12 millimeter, they are losing their GNSF and there is a risk of premature luteinization. You will see commonly in practice, those who are not doing IVF as well, that your client will come on, she will have a 14 millimeter follicle, you call her after 2 days and follicle is ruptured. So this could be, the surge can take place anytime. Okay. So again, we cannot apply the Messinist theory in our real world scenario, and that's why we are still using antagonists as a standard of care in our practice. So what happens? Another point here to note. In all through the career of the follicle, during the course of a stimulation of 10-12 days, the follicle is moving in a low LH atmosphere. Am I right? The first 5 days because of GNSAF, and the next 5 days because you're giving antagonists. So the LH exposure through is much less. Think that you are given OC pills before. Think you are given some depot leuprolide earlier. So the follicle is not bathed into an LH pool for a pretty long time, for 30 days, in spite of the whole stimulation going in. And now you stand a risk of developing less oocyte yield or partial or complete empty follicle syndrome. Okay. That's why when we understand that your LH is going to be low through the stimulation, in my protocols, I prefer using Menopure. I don't have sharings with Ferring company. It comes very expensive to me as well. Because Menopure has HCG instead of LH. So HCG will act, 1 unit of HCG is equal to 7 units of LH activity. So it has about 9.9 units of HCG in a Menopure ampule, so about 70 IU of LH activity in a 150 IU Menopure. That HCG will not die away. It will accumulate. If the HCG accumulates, you will maintain a serum HCG level between 5 to 7 through the stimulation cycle. And that serum HCG level of 5 to 7 is a good baseline LH activity, giving androgen substrate all the time for the follicles to grow better. On top of that, Dr. Goody says that gives HMG in PCO, and this HCG will act as a ceiling for smaller follicles, or lots of smaller follicles will not grow. So you'll get a good mature yield in spite of this. So I prefer using Menopure for this particular reason, because I understand during the course of stimulation, there's no LH. So on day 12 of stimulation, if my LH in the lab comes 0.5, I'm least bothered, because HCG is already there, and I have not measured HCG, I have measured LH. So if I measure HCG, it will come 5 on 6, and I'm happier about it. Okay. Think about it. What happens in older women? So we must understand the whole endocrinological changes which are taking place in older women. The luteofollicular transition is taking place 6 to 7 days prior to the onset of menses. Dr. Sharayu nicely told you the discordance between the FSH values and AMH in her second or third slide. She showed you that the FSH is already, your E2 is already up. The follicle is 12 and 13 millimeter. The E2 is already up. It is suppressing the FSH. So the AMH comes 0.7, the FSH comes 8, but the E2 is 200 then, or E2 is 112. It is not, it's a false FSH. It is suppressed because of the growth of follicle. Okay, so this discordance is because of this. And secondly, suppose you want to start in a low ovarian older women. If you start, let's say, Proguanova just 3 days before the onset of menses, you're not going to act. You missed the bus. The FSH started rising about 7-8 days earlier. Okay. So generally in the follicular phase, they will have a high FSH, high estradiol on day 2 and day 4 of the cycle, and seeing a bigger follicle, a residual follicle, will be very, very high. A residual will be a wrong word. A luteal follicle, which is crossing over to the follicle, will be seen. The follicle of the older woman will have less amount of granulosa cell. The granulosa cell layers are generally supposed to be 10 layers, but they may have just 4 to 6 layers. Hence, less amount of estrogen will be released. Hence, less amount of GNSAF will be released. And hence, premature luteinization can take place anytime beyond 12 millimeters. And obviously, because less amount of granulosa cells, less luteinized cells, less lutein cells, less progesterone, so early menses. So they will have short cycles. It's a complete vicious cycle. So in older women, we have to keep in track of this thing, that they will have all this pathophysiology, and we will assess them properly and then start with our stimulation. That's why Dr. Goody, when he told that track the follicle, chase the follicle, is very, very important. And sometimes you realize when you're chasing the follicle that, well, every time, I've seen her 4 times. Once I saw 1 follicle, second 2 follicle, third 3 follicle, fourth again 1 follicle. So when do I start my stimulation? Can I ever be able to accumulate follicles in her? Okay. And that's where your estrogen pre-treatment can play a role. I had a lot of questions on estrogen pre-treatment. That's why I'm putting one slide. This is one pre-treatment even I use commonly in my practice. The only pre-treatment, rather, we use in our practice is estrogen pre-treatment. If you treat with estrogen pre-treatment, that will be generally 4 to 6 milligrams of Proguanova. You will give it maybe about 7 days or 5 days prior to the onset of menses. Let's say I'm going for ASHRAE conference, which is on 20th of July. So I can't have any pickups between 20th of July to 25th of July. So if I don't want to have any pickup on 20th of July, that means no trigger can go after 18th of July. If the trigger doesn't have to go for 18th of July, so my stimulation, no stimulation can start about 12 days prior. Let's come 12 days prior. So till about, let's say, 7th of July. So beyond 7th of July, for a period of 6 days, I will not be stimulating anybody. Now, I get a lady who comes to me with 29th of June menses and says that day 2, this is 1 lakh rupees, doctor, start off. I look at the 1 lakh rupees first. And she said, I need to start off. But I said, well, there is an asynchrony, madam. So let me give you some Proguanova. I'll synchronize the herd. So I will give Proguanova 2 milligram 3 times a day till the time I'm going to come on 25th. So my stimulation till 13th. So 10 days, 13 days, you take Proguanova. And she will take Proguanova. I'll have a nice look at the endometrium. Endometrium will be beautiful. What will happen to the follicles? Synchronization. You synchronize all the follicles. You're not allowed any follicle to grow. Continuous recruitment is taking place continuously. The primordial, whether you give stimulation or no, the primordials are going to preantral. So that is getting accumulated. So you'll have a nice accumulated herd of follicles there. Start off stimulation. You're not going wrong. Can you do fresh embryo transfer? Now, that's a query. You may not be able to do that. Still, you'll be able to do in a few patients who are a little borderline responders. But not everybody will go for a fresh embryo transfer. But you can do that. And what is the advantage? 1, FSH kept low. Follicle synchronized. Look at that diagram. That diagram tells you in a natural cycle, the LH is low till it surges. And what you give in a progynova, if you give progynova, there's a continuous rise of LH. So what are you doing? You're accumulating LH and you're accumulating LH in the follicular pool, and now you will never have empty follicle syndrome. The biggest risk of empty follicle syndrome is in the women who have low LH to start off with the stimulation. Here in progynova is accumulating follicles. Good enough. So this is one pre-treatment which I feel is very, very beneficial. Ocipils, absolutely no. Progesterone, absolutely no. I only use progynova 4 to 6 milligram as my pre-treatment, not compelled. I give you one example when I want to schedule cycles. It could be asynchrony also. So there are some papers which talk about like give a prolonged progynova, give progynova for 1 month and 2 months. What are you doing? You're not allowing FSH to rise at all. If the FSH is not rising at all, she will maintain. So her follicles will keep accumulating. So down about 1 month or 40 days, instead of seeing 1 follicle, you may see 4. Start off the stimulation, stop the progynova and start off the stimulation. What will happen? You will require higher dose because you're suppressed so badly, and you require a longer stimulation. Agree to that and start off the stimulation. Explain it to the client very well and do it. And even after 40, 50 days of progynova, the follicle remain 1. Tell her, well, you have really bad ovarian reserve. Your continuous recruitment is also not helping you up, and probably think of donor or just allow me to go with that 1 egg itself. So you can, this progynova definitely helps you alter the physiological considerations and manage your cycles further. Any questions on progynova? And I think it gives me one more thing. This is one small tip. Now, in IVF cycle, I always take a picture after I do a pickup of the endometrial thickness. And if my endometrial thickness on that day of pickup is thin, I'm definitely facing a thin endometrium patient. Because there's no reason for estrogen to be beyond 1000 picograms and endometrium to be thin. So, and we start picking up the endometrial pathologies then and there. We are very common advocates, Sharayu and me, of doing hysteroscopies at OPU. We commonly do it. क्या होता है, polyp निकालते हैं, वापस आता है. Okay, and then at the pickup तो वो polyp वापस निकल सकता है. Anyway, freeze-all cycle हो रहा है. So if you find heterogeneous things, you find polypoidal endometrium, heterogeneous shadows in the endometrium, just do a quick hysteroscopy, a DNC. Most of the cycles are anyway freeze-all cycles, so it wouldn't make a difference, but you give one more look at that endometrium. There's nothing wrong in doing that up. Right?